This is the Chapter 10 lecture, and it covers healthcare financing. This chapter includes a lot of discrete information. It is connected, but when going over the slideshow, it's a little bit difficult because there are so many little tidbits in here, so I'm not going to touch upon everything. Be sure to read the textbook carefully. One thing that's very clear is how complex our payment system is, and that has an impact for sure on changes to our healthcare system to improve quality, efficiency, and resources. We need the funding for those changes, and yet our system is very, very complex. We also have to be aware what's happening politically. Of course, the Affordable Care Act made major changes to health insurance and health insurance access, and then the Trump administration dismantled bits of that act. As far as a general overview of healthcare financing, it's listed here. We need to understand how we pay for care, who pays for care, how much we pay for care, and who's using most of the care, which is listed here. 20% are using 80% of the services. So those are individuals who have very high demand on the healthcare system, high cost. As far as healthcare financing, we look at insurance systems and how they work. Individuals pay a premium, and these premiums are pulled across the population. The system works through payers and co-payments and complex reimbursement rules, and it encourages overuse and oversupply because of this complexity. The users of healthcare, the consumers, often do not see the actual price of that healthcare. We've got public insurance programs. We'll go into more detail with them. And we have the continuation, and private insurance. We have the continuation of the discussion or argument about whether healthcare is an economic commodity, like a cell phone or a car. If you can afford it, good. If you can't, do without. If you have lots of money, you can afford really good quality car or cell phone. Should healthcare be like that? Or is it an inherent right? So individuals do pay for healthcare through insurance coverage, through out-of-pocket, or for some who don't have insurance or enough money as a charity case or through safety net providers. Here's a listing of some of our public programs. And here is some more information on private insurance. So there are a number of different ways this can work. Small employers can buy from commercial companies. Individuals can shop on the marketplace. Large employers can self-insure, and you should know what COBRA is. Publicly financed programs, again, privately financed. Read through this. As I mentioned, this slide set is a little bit jumpy in terms of jumping forward, jumping back, but you can see that the percentage of Americans who are covered by employer-based insurance took a pretty sharp nosedive over the past couple of decades. Individual insurance was required by the Affordable Care Act. That was struck down, however, recently in terms of the Trump administration not penalizing individuals at tax time for lacking insurance. How providers are paid for the health services they deliver is so complex, and for people who work in billing, they live this complexity every day. These rates are negotiated, although there are fixed rates for Medicare and Medicaid, and that's really important. The government sets those rates. Private insurance usually pays best, Medicare next, Medicaid lowest. So since financial viability of the providers relies on a payer mix that gives them enough income, at times they will limit the number of Medicare or Medicaid patients they accept into their practice. In times they will stop taking these patients. Payments made directly by patients are those without insurance or those who seek care out of the network of their insurance. Prices being controversial and rarely transparent, this is a huge problem in this country. We don't know what we're paying for. Even when we get a hospital bill, it is so complex and confusing that it's very, very difficult to see what we're paying for before the service is provided or afterwards. So there have been some specialized payment approaches, and your textbook does a good job of looking at these. They include things like accountable care organizations, capitated payments, PPOs. Consumer driven healthcare is a trend that we're seeing right now, where a consumer has a very high deductible, which they must pay before they receive benefits. So, what happens then, because of those very high deductible, the consumer becomes aware of and feels the pain of the cost of healthcare. Now, this may sound like a good thing because then perhaps they don't overuse healthcare, but unfortunately, in these tough times, it also prevents some individuals from using health services, healthcare that they need to stay healthy. Read about reference pricing and transparent costs as well. DRGs are diagnosis related groups as well. Very good.